I'm Dr. Stephen Beeson. I'm host of This Clinical Life, and welcome to This Clinical Life, proudly sponsored by Practicing Excellence. In this podcast, we explore the transformational impact of investing in the growth and development of our healthcare workforce, a powerful yet often overlooked catalyst to positive change. And today, I'm super honored to be able to have an incredible guest and highly sought after guest that he's going to be spending some time with us. We have Dr. Robert Pearl. He's the former CEO of the Permanente Medical Group here in California and the former president of the Mid-Atlantic Permanente Medical Group. He is currently a clinical professor of plastic surgery at Stanford University School of Medicine and a faculty member at the Stanford Graduate School of Business, teaching healthcare strategy, technology, and leadership. He's also author of Mistreated, a Washington Post bestseller, and Uncaring, a critically acclaimed award-winning book. His insights on AI, our topic today, in healthcare have been featured in the Associated Press, USA Today, MSN, Fox, Forbes, Medscape, Modern Healthcare, and many, many other places. And I think you're super busy right now. I see you everywhere. He is also author of the book that I just finished, or just finishing right now, called ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine. Dr. Robert Pearl, or Robbie, as your co-author says you prefer to be called. Welcome to This Clinical Life.
Thanks a lot. It's great to be here. And for your listeners and viewers, all profits from all the books, but especially the new one, goes to Doctors Without Borders, a really great charity.
Oh, that's fantastic. That's fantastic. There's nothing like the power of purpose to make all of this make sense in this world that we're in right now. So grateful for that. My question is, so somebody's already asking the name of the book. The name of the book is ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine. So let's dive in, learning a little bit about you for the 2 or 3 people that may not know you. Tell us a little bit about your journey from being a plastic surgeon to doing hundreds of keynotes and workshops and podcasts across the country, advancing sort of AI knowledge and literacy across American healthcare. Tell us how that journey played out for you.
Well, actually, I can take the journey back all the way to when I was in college. I went there, I was 17 years old, and I wanted to be a university professor. And my hero, a brilliant man who went on to become the chairman at Reed, didn't get tenure because of his political views. And I decided I wanted to go to something that would have no politics, medicine. So that was my foolishness as a ignorant 17-year-old. And I think that's sort of naivete, if you want to call it that. You could call it generosity of spirit or whatever, has persisted throughout. I was a plastic surgeon. I still am a plastic surgeon. I do mission trips. I was in the Philippines last year fixing kids with cleft lip and cleft palate. But I went from being a surgeon full-time to being the CEO in Kaiser Permanente, the Permanente half of the Kaiser Permanente. And I really loved it. We did really well. I was in that role for about 18 years. And what I realized is that as good as Kaiser Permanente had become, and I didn't think that it was anywhere near perfect or the model yet for the nation, but it made tremendous progress. It was #1 in the NCQA surveys. It had access that was about 20% better than the community and satisfaction that was higher. It was time to move on to the rest of the nation. And as you know, I had written several books. Mistreated is all about the system, the broken medicine system that we have. It's fragmented. It's paid on a piecemeal basis. The more you do, the more you get paid. Whether there's any good or not doesn't matter. It uses outdated technology. The fax machine, an 1834 invention, is how we communicate data. And it basically doesn't have a leadership structure. And I went on to look at the culture of medicine that I think is an impediment to change. But what I realized in the end is it needed something. It needed something that would be able to drive the value-based care that we all talk about. We never all can quite agree what it means, but that opportunity we needed to be able to drive. And lo and behold, November 2022, OpenAI releases ChatGPT. And that opened my eyes to, I said, we now have the tool that we need. And what I'd like to do is help the nation get there by recognizing what it can do and embracing it with all the associated changes that need to occur.
One of the questions I have is that, if you talk with healthcare leaders, uh, both, clinical and non-clinical, the question is the power and impact and integration of AI to change American healthcare. It is number one, two, and three in terms of where resources are going and where conversations are guided, and the hope and the prospect of fixing some of the big challenges that we have in American healthcare. Talk to us a little bit about why this is so much different than other technologies that have come about and why this could potentially have the profound impact that people are sort of implying right now.
The most important place to begin is understanding that we should probably never again use the word AI, because there's so many different types of AI. You can go back to the 1980s, actually the work done at Stanford, where she said, I teach in the medical school and in the business school. They had a system that would allow clinicians to use AI technology at the time to diagnose and to decide what antibiotics to give for infections. And it was a rule-based system. The way a rule-based system works is you take a clinical expert, and the clinical expert, a group of experts, provide rules with a set of symptoms. We make a certain diagnosis. With this diagnosis, we prescribe a specific antibiotic. And we use what's called heuristics, these rules of thumb. It's what we learn in medical school. If you're a pathology rotation and you see a slide that has cells that are rapidly dividing, strange, unusual, large nuclei, it's invading tissue, not pushing it away, we call it cancer. But what we know is that someone who's seen 100 similar slides can do a better job than simply a first-year resident who is using these small, as I say, heuristic rules of thumb. And so it didn't really go very far. Around the year 2000, we see what I call narrow AI. This was a shift where the designers of the architecture took a biological approach. They designed multi-layer, deep learning, neural type nets that would be able to generate its own rules. And the way this technology works is you didn't start with a human giving you the heuristics. You started with data sets. Let's say you took 10,000 mammograms, 5,000 showed cancer, 5,000 were either normal or benign. And then it found 50, 60, 70 different small differences, ones that the human eye and the human brain couldn't identify. And it assigned the probability factor to each. And in that way, it's been able to find or to answer appropriately about 10% better than humans. Whether we're looking at radiologists, whether we're looking at dermatologists with melanoma, whether we're looking at ophthalmologists with retinal problems, whether we're looking at pathologists making a diagnosis, because it's able to bring in more information. But what's the problem with a narrow AI tool, and why, although right now, by the way, there's 1,000 of them approved by the FDA, almost none of them are in practice? Number one, it's narrow. You can't use the tool for mammograms to read chest x-rays. But number two, it's dependent upon the data set. And if the data set, I'll say, is clean, so you basically have two radiographs and there are no markers on it that give anything away, and there's nothing unusual except the pictures, it does an amazing job. But as soon as there is slight variation in the excellence of the database, what you see is it magnifies the imperfections in the same way that in a well-designed or well-matched database, it actually magnifies the commonality and comes to a better diagnosis. We saw this with Watson, a very powerful tool, because you can't apply this type of technology to the electronic health record, as an example. You can't use it to make diagnoses coming out of information because clinicians vary in how well they record things. They copy and paste. Errors get introduced. If I say a patient has a pain threshold, a pain level of 6 on 10, and you say it's 7 on 10, which patient has more pain? We don't really know. We assume 7 is bigger than 6, or the application does, but could well be the opposite. So that technology, although it's very sophisticated and very excellent, it has not penetrated. Generative AI is completely different. It's trained not on images and on data sets. It's trained on all the information in textbooks and in journal articles. It'd be like having a resident who had read and memorized and never forgot a single fact from any textbook or journal article ever published. You'd rely on that person a lot for expertise. And that's what generative AI does. It's, I like ChatGPT, MD, the 5 letters flow together, but GPT really should be PTG. It's pre-trained on this totality of information. It then transforms it using 2 billion parameters. Information from new journals is more accurate than older journals. Peer-reviewed is better than non-peer-reviewed. Academic institutions are better than individual clinicians. And then it generates an answer to any question. It does it with remarkable excellence and reliability, even today. And I want to stress one last thing for the viewers and listeners. This technology is becoming twice as powerful every year. 5 years from now, it's going to be 30 times more powerful. A decade, 1,000 times. It'd be like your car going as fast as an airplane 5 years from now and a rocket ship in 10 years. We shouldn't be looking at what exists today, but asking ourselves, how are we going to use the tools that are going to be here in 3 to 5 years?
Well, it's breathtaking. And one of my questions is, if we look at the application of generative AI, and let's take diagnostics, and you have some great anecdotes and stories and data in regards to how it's being used by clinicians as an adjunct for diagnostics. Walk us through that use case a little bit and how a clinician today, tomorrow, a year, or 3 years from now would be using generative AI to help and support diagnostic accuracy.
Well, let me begin by saying, rather than starting with the clinician, we should start with the patient and recognize a couple of things. That patients today want information. I was on a podcast about a month ago, and at the end of the interview, we were off air. The person said to me, my husband was skiing 3 months ago. His arm was over his head. He slid about 100 feet. His shoulder still hurts, and he can't use that arm as well as the opposite side. You're a skier, Dr. Pearl. You're a physician. You know about other stuff. What is it? What's going on? What do you think's happening? And I said, well, I think I know exactly what he has, but why don't you said on the show today you'd never use generative AI. Why don't you go home, use the free version of ChatGPT, put the information in place and see what the technology says. She called me back about 5 days later. She said, thank you so much. ChatGPT said that he probably had a torn rotator cuff. He needed an MRI study, and he should see an orthopedic surgeon because he most likely needed to have a procedure done to repair the problem that he had. Now compare that to something like Google, a browser. It would tell you 100 different causes of shoulder pain. It would give you a differential diagnosis of why an arm doesn't work as well as the opposite side. It would certainly tell you to see an orthopedic surgeon, but not because of your problem. It would tell you to do it because it would protect the application. Generative AI produces expertise. Between the time when we see patients and they have problems, we don't know what's going on. They don't have resources. At 11 o'clock at night, if your kid has 103 fever, what do you do? Do you go to the ER where you wait an hour? Or do you wait till the morning? You look on Google and it says your kid could have meningitis, they'll be dead. You call the doctor's office, they say go to the ER, but it's only because, again, protecting the doctor. We leave the patient in the lurch. This technology is what they will be using. And I could give you lots of use cases. I can tell you about physicians. A surgeon that I know, she did a procedure, a very complex neck procedure. And at the end of the case, the anesthesiologist said he couldn't take the breathing tube out because the vocal cords had adducted, stuck together. And if she took the tube out, it would block the airway and the patient would die. Asked whether she should transfer the patient to the ICU or maybe do a tracheostomy. She pulled out a phone, she went to ChatGPT, she gave the information in place, and it came up with 4 cases where exactly the same thing had happened. Because the anesthetic that we use in order to use the adrenaline that sits inside anesthetics diffuses in some patients too far. She hadn't damaged anything. It's just the anesthetic had gone to the vocal cord, to the nerves, to the larynx, to the vocal cord area. And in all 4 cases, the patient got better when the anesthetic wore off. She said, no, let's just wait 30 minutes. 30 minutes later, the cords separate, tube comes out, the patient goes home. That is the kind of expertise that we are talking about. But I want to stress the bigger use case, which is chronic disease. If you ask me, why is medicine in so much trouble today? Why do we have such high burnout rates? Why is it that costs are rising so fast, but quality is not improving? I think we've missed the mark. We failed to recognize the impact that the crisis in chronic disease has had. Think about it this way. A patient walks into your office, they have right lower quadrant pain, you diagnose appendicitis. You'll see them 4 or 5 times, you do a procedure on them, and then you're done. As soon as someone walks in your office with diabetes, you've now booked the next 120 visits because you'll see them 4 times a year for the next 30 years. That's a totally different demand. Doctors are seeing patients every 17 minutes. They're on a treadmill racing forward because there are so many patients. Supply can't keep up with demand. And that, I think, is the challenge. So when I ask myself, how do you use technology to solve this problem? What I see is that we do a poor job today. We control hypertension, the number one cause of strokes, 40% of strokes. We control it 55, 60% of the time. Diabetes, between diabetes and prediabetes, we're talking a third of the nation, and we control it less often than even 50%. The CDC said that if we can control heart attacks and strokes effectively, not perfectly, just effectively, as well as the best organizations can do it, but they do it by having a lot of nurses and pharmacists, which is very expensive. But if we could use technology to do it, we'd reduce heart attacks, strokes, cancer, and kidney failure by 30 to 50%. Now ask yourself, if we had 30 to 50% fewer heart attacks, strokes, kidney failures, and cancers in the United States today, what would that do to health? And what would that do to cost?
It's extraordinary. And my curiosity is, as we look at the use of generative AI in diagnostics and empowering patients, and I'm thinking about a patient recently that I had a conversation with, and he has a lumbar radiculopathy. He's got suggestions on his MRI scan that it could be L5, S1, it could be L4, S5. He's had 2 epidural steroid injections at both levels, both provided suboptimal impact. And an orthopedic spine surgeon that says, could be one, could be the other, not quite sure. The point is nobody's agreeing. There's no continuity and approach, and the patient's left with a refractory condition with an unclear diagnostic and therapeutic pathway. And I'm drawing a conclusion that, if we were to put complex information that could look at images, look at all the literature, and have the capacity to evaluate, that sort of constellation of complexity, we may be able to find something that the singular biased human tired mind may not come up with. What are your thoughts on using AI in cases like this, where there's different opinions, there's sometimes contradictory clinical data coming in? Talk about the use of AI in these kinds of complex cases and what you're seeing and envisioning.
We have known for over a year that this tool is very good at making diagnoses. A study out of Harvard showed that it was as good as the typical attending or resident at diagnosing complex problems. We know from the University of Arizona that it is actually better at responding to patients' messages, both 4 times better in terms of the quality and comprehensiveness, 9 times better in terms of empathy. We know studies show that if you take ER doctors at the point that they've now seen the patient and done the initial evaluation and physical examination and come up with a tentative diagnosis, and you give exactly that same information to the generative AI tool, the generative AI tool will outperform clinicians by 10%. And just this month, or last month, in October, people from Stanford published a paper where they found that clinicians alone, using standard medical textbooks and journals, were able to make the right diagnosis 73% of the time. You give them access to generative AI, they're now able to do it 77% of the time. You give the same problems to generative AI alone, 83%, 10% better. So I don't know that it's a question of pure resolution as opposed to accuracy. And I'll go back to what I said before, because everything I'm saying is hard for doctors to accept. I mean, it's going to mean we're going to change what we do and how we create value. And we all want to say, no, machines can never be as good. Well, let's just look at the data that's there. But I'm not even looking at what exists today. I'm asking myself, if this tool is going to be 8 times more powerful in 3 years and 30 times more powerful in 5, what's it going to be able to do? It can access every piece of information. We just can't do it. We don't have the time. We don't have the brain capability to accomplish that. And will it make mistakes? Probably. The question is, will it make it less often than with clinicians? And so how do we develop a different relationship? Because there's no question in my mind that an empowered patient and a dedicated clinician and this technology will be 10 times better than any of the 3 alone by the time 3 to 5 years have passed.
I was reading an article out of McKinsey that just came out, I don't know, a couple of months ago, where there was reference to clinicians' technical skills in the use of technology will be more important than their clinical knowledge in regards to today's and tomorrow's clinician. And
I,
yeah,
I think the biggest thing is going to be the human to human relationship, because even though I told you that empathy was higher with the technology, there's something about talking to a person that is going to be different. If what you have is a message you're sending, I think empathy can be communicated. If I have cancer, I want to have a human that's there, even though from a totally theoretical basis, the technology could be better. There's something about, I think, humans. And so that's where I think the first level of emphasis is going to be. And I think, unfortunately, over the past couple of decades, we've seen a deterioration in our ability to have these kind of human-to-human contact because we've been moving so fast. You can't do it in 17 minutes when you have an acute problem to solve, chronic disease to review, medications to change, and you run out of time before you actually talk to the patient about something. We interrupt our patients, I think, after something like 17 seconds or something like that on the studies that have been done. So I think that's the first thing. I think the question on the technology is going to be interesting. And I'll tell you why. And no one is yet talking about this, but when I look at, I'm a surgeon. What do surgeons do these days in the operating room? They use robots. And they actually don't actually touch the patient. They sit in a chair, they're looking at a monitor, data's coming in, they can see what's going on, and then they pull a bunch of levers based upon what they see. That sounds to me like a large language model. What does a cardiologist do? Unblocking a coronary artery. You stick a catheter in the groin, it's 2 feet away to the heart. You can't manipulate that catheter. You can advance it, you can pull it back, you can inject some dye, you can, to figure out what to do. The number of moves that you have are limited. And I suspect it's a lot harder to create a self-driving car with all of the vagaries that can happen and to figure out how to use an operative robot or a catheter in a catheter lab. I don't know how much of the technology is going to be done purely by humans and how much is going to be accomplished through this technology. That's a decade or more away. But I think the people who assume that technologically will always be the answer, I think that may be very presumptuous.
what's really interesting is what you reference is the power of human to human connection. And in the context of a new diagnosis or managing chronic disease or a new serious acute illness, I can never envision uh, technology, despite its capacity to evaluate information and tap data sets and learn over time to create accurate diagnoses and evidence-based treatment plans, that there will ever be a replacement for the humanity of the clinician-patient bond and what that's like to walk patients through that illness, but incredible capabilities to be able to power evidence-based diagnostic accuracy and empowering patients to care for self in the process in chronic disease management, which is 70% of all American healthcare spend. So, it's incredibly it's incredibly exciting. I heard one reference that, and I want to get your take on this, is that 80% of clinicians could be replaced in the next 3 to 5 years using generative AI and diagnostic bots. But talk to us a little bit about that for those that are freaking out, saying these bots are going to be replacing us. Talk to us a little bit about how you see that playing out.
Yeah, I think that quote came from Vinod Khosla, who was on my Fixing Healthcare podcast earlier this month. He said 80% of what doctors do will be replaced. But I don't believe that 80% of doctors will be displaced. And let me offer a couple of thoughts about that, because I think this is a very important area that sits in place. I think today, first of all, we have a shortage of doctors. Estimates are we could be as short as 100,000, and we have 70,000 people retiring every year. I think our big problem is we don't have enough clinicians. We're not going to have too many clinicians that sit there. Number two, even if we had enough, the pace we're going at is not sustainable. The idea that we can see that many patients a day, 17 minutes per patient, it's just we're not giving the care we should be giving to our individuals. The reason why we only control hypertension 55 to 60% of the time is not because we don't know what to do. We just don't have the ability to do it. We see someone in the office and we say, your blood pressure's elevated, start a medication. We see him back and we'll see you back in 4 months. What happens in those 4 months? We have no idea. They come back in, their blood pressure's elevated. We see it's a white coat syndrome. Come back in 4 more months. Imagine being a patient at home where a wearable monitor is able to take readings 3 times a day. And a generative AI tool can now analyze it. At the end of the month, the wearable says you have 100 readings, 92 are normal, 8 are abnormal. How are you doing? I'm doing great, 92 are normal. I'm doing terrible, 8 are abnormal. No, you have no idea how you're doing. And I can't find a single clinician who wants their patients sending them 100 blood pressure readings every month. The generative AI tool can look at it. It's a simple problem, first and second derivatives. It can say after 1 month you're doing well, continue it. It can say after 1 month it hasn't had any impact, and your doctor can now intervene. It can take out the things that are very routine that we could ask a nurse or a pharmacist to do, but it's expensive. This becomes a way to do continuous monitoring that is there. And so I think we need to see half the number of patients just spend twice as much time with each, or some formula like that. You know, the big problem isn't that we don't know how to save lives. It's that we don't get it done. And that can be the patient, it can be the doctor. It doesn't matter. Right now, there's just not enough time there. And so I think that that's going to become the role. But I do want to add one piece, if it's okay, which is a reality test, which is that if we were to eliminate 30 to 50% of heart attacks, strokes, kidney failures, and cancer, and you're paid on a fee-for-service basis, your income goes way down. That's absurd, of course. Why should your income go so far down when you're actually doing an amazingly good thing for people? The need we have is to evolve American medicine, to move to some sort, I like to use the word capitation. All your viewers are clinicians, so they know what that means. A single payment, not at the insurance level, like we do today, but a single payment paid directly to the clinicians providing the care to be able to prevent disease, to manage chronic disease, and to benefit when we avoid heart attack, strokes, kidney failure, and cancer. It's a win-win-win. It's a win for the payer, it's a win for the patient, and it's a win for the clinician. And I think the faster we can evolve American healthcare in that direction, the sooner we're going to actually align incentives and be able to use this technology effectively.
It was really interesting. You had a co-author on ChatGPT.
Yes, I did.
And talk to us a little bit about that decision and
Sure.
who that co-author was, which I found, I mean, Robbie, you're a great writer, and it's almost like reading a novel. And I remember I was having dinner with my parents, and I said, I got to go home. I got to go finish the book. And because it was a science fiction adventure that is playing out right in front of us in this revolutionary time. But you had this co-author who was also a brilliant writer. Tell us a little bit about your co-author.
Well, it's better to start with previous two books, Mistreated and Uncaring, books that I wrote by myself with a traditional publisher, an editor, and the entire process. And it took about 2 years. By the time you write it, you edit it, you print it, you distribute it, and everything else. And I said, if this technology is doubling every year, anything I write 2 years from now is going to be wrong. So I said I need a different approach. And I also said, if I'm going to be writing about a technology that's capable of doing remarkable things, how can I not use that technology? So I decided to make ChatGPT my co-author. And I approached it the way I do with a medical student or a resident, because I write a lot of papers with medical students and residents. And I said, okay, I'm going to start by downloading the 1.2 million words that I had previously written into the application, the same way I would tell a medical student or resident, go read the research that I've published in the various journals that are there. And then with that, we'll go back and forth. I'll create a draft, you'll create a draft, I'll give you my draft, you give me your draft. And each chapter was probably had 30 rounds of editing that is there. There are two places that are written, I'll say, almost essentially by ChatGPT. 6 pages in total, and they're very well delineated. I explained to the reader that's there. So readers can see what it would be like if ChatGPT were to write the whole book. But this is really, as you say, a co-authorship between myself and the technology. And I think what it shows is that this technology will significantly impact, I think, the publishing and writing business. That's all over the newspapers, as you well know, but equally significantly, how radically it's going to change and transform American medicine. The only question is, are we going to lead it from inside the profession, or is it going to be disrupted from someone outside?
I've got to read something from your book, and I shared this with you because it was incredible. I mean, it's written by ChatGPT, and I want to read this paragraph just to get a sense of, for those that haven't read the book yet, which I highly recommend. And this is ChatGPT, and this is in I think at the second chapter. It says, "What sets me apart from my predecessors isn't just my technical prowess. It's my ability to interact, understand, and assist in ways that were once thought to be the exclusive domain of humans. Unlike past generations, I'm not limited to a specific task. I've been trained with massive data sets encompassing almost all publicly available information. This training allows me to generate human-like text, music, art, intelligence, and computer code with great facility by applying the patterns I've learned to whatever question, request, or prompt I am given." I mean, it's extraordinary that we're alive at a time that this is coming, and the speed and the pace by which it's increasing. Uh, and one of the things that I think is really, really compelling is, how do we get a reimbursement model that allows this to grow so we don't implode economically? Because you're right, the fee-for-service model, in which we're doing upstream care, patient empowerment, patient enablement, patient self-care, disease prevention, chronic disease management, all of which reduce disease burden for patients and populations. In that context, the fee-for-service model that doesn't play out. So we have to figure out how we set up incentives to allow the advancement of generative AI's influence on American healthcare. We've not been great at advancing value-based care, and I would say it's decelerated over the past 2 years. What are your thoughts in terms of the probability of us being able to figure this out? Because if we don't, then this thing is it's not going to grow the garden that we all think it can and should. So what do you think in terms of cultural, economic, policy issues that can serve as facilitators or headwinds in the application of generative AI? What are your thoughts on that?
So later this month in Forbes, I'll be publishing an article where I specifically tackle this question and offer a path forward. I'll call it an intermediate step. I think the problem with moving to full capitation is it's so hard to do. You need to create an entire group of clinicians. Well, that's hard to put together. You need to re-evaluate how you pay people. You need to have a leadership structure that's skilled at making things happen. You need to take often two-sided risk. It's just too big a leap, I think, and that's been one of the challenges that sit in place. And yet I'm a big believer that primary care needs to be the foundation. I'm a specialist. I fix kids with cleft lip and cleft palate, but still, I recognize that if we're going to take on chronic disease, it's going to be primary care that's going to be responsible for it. And I think, in essence, what we should be doing is moving from a system where we evaluate and reward people based upon metrics. Did you order the 5 right tests? Did you do the 7 right procedures? All the pieces, there's estimated to be 57 different things a primary care clinician would have to do to practice the best medicine, evidence-based medicine that's available, and make it very, very simple. Here are the key diseases that's sitting in place. And what we're going to do is we're going to reward clinicians, starting with primary care, based upon their ability first to change the outcome. What's the outcome mean? Well, if you have high blood pressure, did you lower the blood pressure? If you have diabetes, did you bring blood sugar back down? And how do we then apply this technology and make it available to patients to then be able to measure those things in an easy way? MIPS and macro, that's not value-based care. That's just a lot of work to generate a small amount of dollars, and then be able to use a shared service approach, a shared savings approach to accomplish that. And I think that could be done for Medicare, for Medicaid, for commercial insurers, through insurers. It could be done for self-funded businesses. There's no one who could not put that in place. And by the way, if we didn't do any better, you wouldn't pay anything out. So there's not much you can lose as a consequence of doing that. That's one way I think that can happen. The other way it can happen is that someone's going to disrupt us. Someone's going to come in and basically create such a system and demonstrate that, done well, it should be able to lower costs by 20%. And not only lower cost 20%, but achieve far better clinical outcomes. And I don't know which one it's going to be. There's certainly a lot of people out there who are potential disruptors. A company like Amazon is a really good example of who could lead the way. Or, on the other hand, what we could see is that it's led by medicine, and that we actually go and we ask elected officials to make this change, to create the program. I think the ideas of moving to this full accountable care organization with complete capitation, it's just too big a leap. That's my conclusion. It's the right thing. Everyone says it's the right thing. What does Charlie Munger say? Tell me your incentives and I'll tell you the outcomes you're going to get. Pay people on a pay for volume, they're going to increase volume. It's not that they're bad people or anything like that. They're highly dedicated. That's the system. Tell me the rules, I'm going to play by the rules. But all of a sudden move to some kind of system that rewards them for better control of chronic disease. And then 5 years from now, it starts to reward them because we're going to base it on the number of heart attacks and strokes and kidney failures and cancers that your patients have, or have a serious complication from, or require hospitalization around. It's a lot of different ways it could be structured, much simpler. And I think it starts to align that. It elevates for the primary care physicians on the line their importance. It pays more, assuming that we're able to be successful. And I don't think it takes away from the specialists, because the money that's saved is saved in the wasted areas. It's not saved by cutting back. I mean, look at Medicare right now. It's planning to lower reimbursement to clinicians by 2% next year, at a time when we know inflation raised costs by 5 to 10%.
Right.
There's an imbalance in thinking. And so I'm hoping that, it takes a crisis to make major change happen. I think that's where we are. I'll be disappointed if we're not.
Well, it's interesting that still 70% of our healthcare spend is on reactive care.
Yeah.
And if you think about the constellation of value-based care, it's preventative care, it's evidence-based care, it's patient empowerment, it's whole person care, it's activation of patients to take ownership of their own health outcomes. It's taking into account all the other influences on health with social determinants. It's all the right things. And there's no clinician or care team or system that wouldn't look at that and say, that's the right thing to do. But we've got this death grip on our fee-for-service model. And what an incredible enabler of the value-based care journey that generative AI could be. It's the ultimate capacitator for diagnostic accuracy, patient empowerment, interval care, continuous care, all the things that that make value-based care work, that the generative AI could be the soil to have that garden grow. So
100% correct. I think we still have a fee-for-service system because we haven't had the tools to move away from it. It's been the common denominator of measurement. We haven't had tools that told us how our patients were doing clinically. If you look at even how at most of the claims and billing processes, it's about diagnoses. We asked, did you prescribe the medication? Not did the patient's blood pressure come down. And now we have a tool that not only can facilitate that, make it happen, it can actually measure it, tell us how we're doing, allow us to learn from the best. I think this is an opportunity that we just never have had. And that's, again, why I come on podcasts like this, to try to encourage people. Try it. Let me know how it goes. Tell colleagues about it. We're going to find that there's just remarkable things that we can do with it. To the point you made earlier, I was speaking this summer to the CEOs of the 80 of the biggest companies across the nation. At the end of my talk, one of the CEOs came up and said, my daughter had a problem. For 18 months, we traveled to every great institution to try and diagnose it. No one quite knew what it was. Well, I was sitting there, I put the information into ChatGPT. It gave me a 3 diagnosis differential. This was at the top of the list. It was a very complex autoimmune disease. It was classical, but very, very rare, beyond that, which people had seen often enough to put at the top of their list. That's an opportunity that exists right now. Why would we not want to embrace it? And yet, as you know in the book, and I really appreciate the nice things you said about it, if any technology slows doctors down or lowers income, it's not going to be used. This technology used well will speed doctors up. And if we create a capitated system, will actually increase their income, particularly in primary care.
I want to ask in my last segment of questions is that how generative AI could reduce burden of care teams, because we know what the state of clinician burnout is right now. It's a tragedy, and the principal symptoms of burnout are exhaustion, depersonalization, cynicism. You inoculate organizational cultures with that sentiment; those are highly contagious. They diffuse, and people show up to work on Monday saying, "Good Lord, when do I get out of this?" And that's a very hard workforce to really facilitate meaningful change. So talk a little bit about how generative AI could have clinicians go home at the end of the day and say, that's exactly what I was hoping medicine would be for me.
If I gave you a job that took you, let's say, 30 minutes per person to get to do your best, and the outcome of your job was life and death, and at the end of the day, you only had 15 minutes per patient, so you saw twice as many people, how would you go home at night? Unfulfilled.
Yeah.
Talk about moral injury.
Right.
We've thought that this is something someone's doing to us. And I go back to this notion, what's doing it to us from my perspective is chronic disease. The demand is just there. Now, you could say, okay, let's just double the number of doctors. Sure, that could work. It's going to end up doubling the cost of medical care, or at least, a significant amount of that. And so it's just not going to be possible. So that's where I see the burnout. That's what I think is driving burnout. I think the burnout is being driven by the imbalance in the supply and the demand. Yes, the EHR is very frustrating. And I don't know how many people have tried the ambient tools to listen in on the conversation and create EHRs. They're excellent. And by the way, I have no connection with any company I'm speaking about today. So but every doctor I talk to says this is saving them 1 to 2 hours. So I see a little opportunity there. People hate the prior authorization. So why would we not want to take a capitation? Well, we don't have to ask anyone. We have the money, we provide the care, we do the right thing for our patients. It comes down to this idea of saying, do we have the tool to succeed at the task? Because if I give you a task to do it, now you're at risk for it and you don't have the ability to do it in a way that is, I'll say, reasonable economically. And that's been the challenge. We could have done it with enough resources. It's just that no one's going to actually pay us to do it. And they haven't cared about our burnout because they don't have an alternative. And now we have the alternative to take it away. And I'd like to think that if all of a sudden we could see the patients in our office with enough time who needed care, but not take care of the ones who were not there, not by not seeing them because they were doing well, I think we'd feel a lot more satisfied. If out of, let's say, 100 patients with hypertension, 90 of them are doing well, responding to the medication, we don't need to see any of them. We bring them in because we don't know how they're doing. The opportunity to know they're doing well. And we're going to spend a lot of time with the 10 who are not, because that's what we can do as humans. It's not a question of the medication. There's something about their life that's not working. I don't know what it is. Each one of them is going to be different. And now I go home feeling like, wow, I really made a difference. What do doctors value the most? Our ability to help people. And what are we not able to do today? Invest the time that's needed to accomplish it. So that's where I see us going. That's why I think it's actually going to be a massive tool to do it if we do it well. Will it be different? Yeah. Some of the things maybe we valued in the past, different. But that's the evolution of medicine. We used to think that the sine qua non was physical exam. Then MRI and CT came along. And it's not that physical exam is not really important. It's just not as important as it was. And these other tools become more important. We have other technologies. The iPhone came along, and how can we use that to use information and do better? It's not memorizing the Krebs cycle for whatever good the Krebs cycle is anymore, but being able to access information around. And now we have this tool that could lower heart attack, strokes, kidney failure, and cancer by 30 to 50%. I think if we did that and we were not harmed financially, in fact, if we did better financially, I think burnout would crash through the floor and we'd go home a lot more satisfied and we'd feel as though we chose the right profession. And I'm not sure everyone feels that way today.
Beautifully said. And the word that I'm hearing and the data that I'm reviewing is that the ambient listening tools are making an impact. And we're still relatively early days, but I had a conversation with a clinician the end of last week saying, this has saved my clinical life. I am able now to fully connect with patients. I get better notes and I'm spending more time with my family and I'm able to do the things that I love to do, which is talk, connect, educate, and activate patients to advance their well-being, wellness journey. And AI will be at the centerpiece of ambient listening tools to generate notes for clinical documentation, which is a big part of the administrative burden. And so there's so many different opportunities, Robbie, that we're seeing now. I'm trying not to bring my cynical self into medicine's capability to shift and adopt and change because golly, it's like shifting an entire battle group and getting it to shift 180 degrees. It's hard. And so each of us will do all we can to advance the adaptive use of technology to make American healthcare better because it's not doing great right now, per your prior two books that you wrote.
If half of the patients that we have to see today can have their problems solved as well as if they came in to see us, and we can spend this double the energy on the people who need to come in, because that human-to-human relationship is so key in their situation. And if, as a result of all of that, our patients were healthier with fewer life-threatening problems, if costs became affordable, and if our own income, rather than going down, actually went up because we were successful, how could that not be a successful solution to the burnout that clinicians feel today?
Yeah.
I don't see any way it could not work if we can accomplish it, and we have the tool today to do so.
Well, it's very exciting. And I think the last question, I have 100 other questions, but we need to wrap up. But where is a good place outside of the ChatGPT MD, empowering patients and clinicians to take back American healthcare? Where's a great place for people to learn about generative AI in healthcare? What are you recommending these days in terms of, because everybody wants to learn more about this?
Well, I'm going to offer you an interesting solution. Do you have any kids?
I do.
How old are they?
28 and 25.
All right. Well, they may be a little old, but how do they learn? Do they go to a textbook and try to find an article on how to use a new technology, or do they start using it? And if they're 13, 14, and 15, all they do is take it out and start using it. I guarantee you that right now. and they get a lot better than we get. Don't go reading a book. Use the technology. I think it's worth $20 a month. Every Sunday night, my wife and I sit down and we say, what do you want to eat this week? And we're going to, maybe we ate too much before. We want to lose a little bit of weight. Maybe we want to get a bit more protein. We give the information to ChatGPT, which is the application I use. By the way, it could be Gemini, it could be Claude. It doesn't matter which one it is. It gives us a shopping list. It gives us the menus. It gives us the recipes. Soon, very soon, it's going to bring the food into our house. That's the use this. Pretend you're the patient coming into the office today. Put the information in place. See the information the patient would have had. Take the patients you saw today. Put the information in place. See what is happening. Use this again and again. It takes about 10 hours to get really good at it because the first prompt, it's called, the first question you pose is never the final answer. After you get that information, you say, but what happens if the fever's lasted 3 days instead of 1 day? What happens if it spiked to 105, but most of the time it's 101? Give as much information as you can. Was the shoulder pain after the ski accident? Did it happen when they were lifting weights, or did it happen when they were happened on its own without any force? Those questions, and I guarantee you that after you've done it for a little while, and you will have learned more than you're going to learn in any textbook. And having learned all of that, you will find the uses in your practice, for your family, for your patients. And then if together we can figure this out. And I'll add one more piece that I'm hoping to get accomplished. And like yourself, I speak at a lot of the big organizations, and I'm encouraging them. The insurers, I'm encouraging the NCQA last week, HLTH, all the different places. We don't need to have every doctor figuring this out, him or herself. We need to create common information, whether that's going to be links or published, or material we can hand out. We need to help our patients figure this out as well. But there isn't any great variation. It's just, how do you use this technology? So for the 13-year-olds, the 25-year-olds, they'll figure it out just by using it. We can do the same as clinicians, but for our patients, many of whom may be elderly, we need to give them something they can use that's going to take them step by step through it. And it's like every other technology. The first time you use it, you're totally lost. But by the time you use it 5 times, it's second nature. That is what's going to happen with generative AI. It could happen through chatbots. I mean, someone else can do it for us. That simplifies it. I don't even think that's necessary. I think we can actually use the tools that exist today to start improving our work in our medical offices, to start improving the health of our patients, and as patients, being able to improve our own health.
Well, very exciting. And I'm grateful for your advocacy for this, for American healthcare, and as generative AI as an incredibly powerful pathway to enable a lot of the things that have been very, very difficult to do in our traditional model. And this is as big a change that American medicine will see in our lifetimes. Again, per Robbie Pearl's recommendation, download ChatGPT or your tool of choice and get to work and begin to learn and discover. I'm using it daily for my life in medicine and out of medicine and all of my professional and personal endeavors. It's extraordinary. So Dr. Pearl, I'm so grateful for you, again, your work, and keep your head up, because I know that I think you've said you've given 100 lectures over the last 4 months or so. Take care of yourself in all of this, because we need you, and a whole bunch of other folks like you. They're advocating for making American healthcare better for those providing it, those receiving it, and the communities that we serve. So really grateful for you. Thank you.
We're all in it together. Let's learn together. If people read the book and they have questions or criticism, please reach out to me through my website, robertpearlmd.com. And I think that together we can make American medicine the best in the world. And today it's not, but I think we have the potential. We have the smartest people. We have the resources that sit in place, and we now have the technology that we can use. Let's lead the way for the entire world.
And now we can say it's possible. All right, Dr. Pearl, thank you very much. And this clinical life, we are out.